Welcome everyone to Transfusion Vitals part 2 of our transfusion reaction series. In part 1, we have covered the acute hemolytic transfusion reactions AHTR, the most dangerous of all reaction. Today we move through the remaining major reactions types that every transfusion medicine professional must master. First is FNHTR, febrile non-hemolytic transfusion reaction, the most common reaction. Next, we're gonna see the allergic and anaphylactic reactions ranging from mild urticaria to the life-threatening collapse. Followed by that, there will be TRALI and the TACO. So by end of this session, you should be able to recognize each reaction, explain the underlying mechanism, and confidently manage each scenario step by step. So let's get started. So this section will cover the febrile non-hemolytic transfusion reaction FNHTR. So before we start, there is febrile and non-hemolytic. So both are the critical qualifiers. Febrile means fever is the dominant feature and non-hemolytic means there is no red cell destruction. This is what distinguishes it from the deadly AHTR. FNHTR is a most frequently encountered transfusion reaction in clinical practice, which is exactly why it demands our attention. You will meet this reaction regularly at the bedside. The ability to confidently diagnose it and most importantly to safe exclude the dangerous mimics is a core clinical skill. Approximately 0.1 to 1% of all transfusion, the rate is higher with the platelet concentrate because platelets are stored at the room temperature for longer, allowing greater cytokine accumulation. How we can define FNHTR? FNHTR defines as more than or equal to 1 degree Celsius rise in temperature. This is a threshold. It does not need to be dramatic fever or even a degree rise during or within 4 hours of the transfusion qualifies as FNHTR. This 4-hour window is important because symptoms outside this window will be less likely to be FNHTR. Without hemolysis, you will see hemolysis in AHTR. So there will be no hemolysis. The three diagnostic gates on the right are the exclusion checklist for this reaction. First is AHTR, that is acute hemolytic transfusion reaction. Check for the back pain, hemoglobinuria, falling BP, rising creatinine, and perform the clerical check first. That is wrong blood transfused to the right patient or right blood transfused to the wrong patient. Then sepsis. Bacterial contamination of the blood product can cause identical fever. Check for the rigors, hypotension, very high fever more than 39 degrees Celsius. Cultures from the patient and the blood bag need to be sent. And then third is the patient underlying condition. For example, if a patient is having lymphoma, there will be natural febrile condition of that patient. So always check the pre-transfusion temperature baseline. Now the pathways, both ultimately resulting in the cytokine driven fever. Pathway A is accumulation. This is the storage lesion pathway. During storage of blood components, particularly platelets and red blood cell, donor white blood cell, that is leukocyte, breaks down and releases the cytokines like interleukin 1, interleukin 6 and TNF alpha. These will accumulate in the bag over time. When transfused, these preformed cytokines directly trigger the hypothalamic fever response in the recipient. How we can manage this? We can manage by doing the leukoreduction or leukodepletion, by removing the white blood cells from the blood component before the storage. So we can prevent the source of the cytokine accumulation. Pathway B is a reaction. This is the immune pathway. The recipient has preformed anti-HLA or anti-HNA antibodies, typically from pregnancy or prior the transfusion. These antibodies react with donor leukocyte in the transfused product, triggering the recipient cytokine release. How we can manage? The management protocol is to stop the transfusion immediately. You must first exclude AHTR, then administer antipyretic. Restart at slower rate once the AHTR and sepsis are confidently excluded and fever is settling. For recurrent FNHTR, pre-medicate with the paracetamol 30 to 60 minutes before the future Transfusion. Use exclusively leukoreduced blood products. Never restart the transfusion without excluding the serious causes first. So this is the patient safety is not negotiable. Next is the allergic and anaphylactic reaction. So this section covers the entire spectrum of hypersensitivity reaction to transfused blood components from mild and common urticaria at one end to the rare but potentially fatal anaphylaxis at the other. So mild allergic reaction, that is the localized skin reaction, only urticaria, pruritus, manageable, transfusion can be restarted. But for anaphylaxis, it's a systemic multi-organ collapse which require immediately life-saving treatment and transfusion must not be restarted. According to the epidemiology, mild allergic reactions occur in approximately 1 to 3% of transfusion, making them one of the most commonly encountered reactions. Anaphylaxis is far rarer. It is estimated as 1 in 20,000 to 1 in 50,000 transfusion. This slide covered the mild end of allergic spectrum, confined to the skin with no systemic involvement. Clinical features include three cardinal signs. First is urticaria, hives, the most common symptom, raised, itchy, erythematous, wheals appearance during the transfusion, classically described as blotchy and well demarcated. Pruritus, intense itching, often preceding visible skin changes. And third cardinal sign is flushing and erythema, generalized redness, particularly of the face and upper chest. In the mild reaction, there is no hypotension, bronchospasm, stridor, angioedema, nausea, or vomiting. If any of these appear, you have to move into the anaphylaxis territory and must escalate immediately. The management pathway include administer the antihistamine, wait for complete resolution, do not restart while symptoms are still present, and the decision gate once it is completely resolved, you can restart the transfusion at a slower rate but with the close monitoring. For the patient with recurrent mild allergic reactions, consider the wash blood products, that is plasma removed in the refractory cases. So this is the critical emergency slide. Anaphylaxis during the transfusion. It is rare but immediately life-threatening. Every healthcare profession must know this code. So the onset is the key distinguished feature from the FNHTR is speed. Anaphylaxis begins with seconds to minutes of starting the transfusion, sometimes before even a few mLs have been infused. This is the distinguished feature if a patient develops severe symptoms very early in transfusion, that is within first few milliliters, think of anaphylaxis, not the FNHTR. The pathophysiology is having a link with the IgA deficiency. So approximately 1 in 600 to 700 people are IgA deficient. This is a subset of these patients develop the anti-IgA antibodies, usually prior transfusion or pregnancy. When they receive any blood component containing IgA, which is present in the plasma, platelet, or FFP, their anti-IgA antibodies trigger massive mast cell degranulation and complement activation, which leads to systemic anaphylaxis. So, four cardinal clinical features include shock, severe hypotension, that is because of massive vasodilation and the capillary leak. Then, second cardinal sign is bronchospasm, wheeze, tachypnea, oxygen desaturation. Third is angioedema, swelling of lips, tongues, larynx, airway emergency. Fourth is urticaria, present but not the dominant feature, unlike the mild allergic reaction. You can also see nausea, vomiting, abdominal cramping, loss of consciousness in the severe cases. Management slide for the anaphylaxis. Step 1, to stop the transfusion and keep the IV line open. Do not restart the transfusion as in mild allergic reaction we used to restart, but in anaphylaxis this is the absolute contraindication. Step 3, the primary treatment is with the adrenaline. Why? Because alpha 1 adrenergic effects the reverses the vasodilation and angioedema, whereas beta 2 effect bronchodilates and beta 1 increases the cardiac output. So give that as IM. Secondary support include high flow oxygen, IV fluids, antihistaminics, steroids. For future prevention in these patients must be investigated for the IgA deficiency, serum IgA levels plus anti-IgA antibodies. If it is confirmed IgA deficient with the anti-IgA antibodies, all the blood products in the future must be washed prior to the transfusion. Next is TRALI and TACO. These are the two major pulmonary complications of the transfusion. This is arguably the most clinical important section for the patient outcomes. Both these conditions present with the respiratory distress and hypoxia during or after transfusion. The challenge and the critical clinical skill is to distinguish them from each other because their management is opposite. So TRALI is a non-cardiogenic pulmonary edema, that is antibody immune mediated, and it is treated with the oxygen plus minus ventilation. We have to avoid diuretics in this. For TACO, it is a cardiogenic pulmonary edema, volume overload. So we have to treat it with the diuretic and oxygen. According to the epidemiology, TRALI is the leading cause of transfusion-related mortality worldwide, whereas TACO is an underreported serious complication thought to be significant more commonly than the TRALI, but often attributed to the patient underlying condition rather than the transfusion. TRALI, that is transfusion related acute lung injury. So we have to memorize the diagnostic criteria. TRALI is the number one cause of the transfusion related death globally. It must be on your radar for every patient receiving the plasma containing blood product. The diagnostic criteria, all conditions must be met as per the ISBT or ARDS network consensus definition. So there will be acute onset within 6 hours of transfusion. The time window is critical. The reaction more than 6 hours post transfusion can be classified as possible TRALI or delayed TRALI. Second is bilateral pulmonary infiltrates on the chest X-ray. So there will be bilateral fluffy non-homogeneous infiltrates, sometimes described as the batwing pattern. It is important that in this the heart size is normal, unlike TACO where there is a cardiomegaly. Third is there is severe hypoxemia. Partial pressure of oxygen or FiO2 ratio will be less than 300 mmHg and the SpO2 will be less than 90% on the room air. This is the ARDS definition threshold and the patient is significantly hypoxic, which can be deteriorate rapidly to requiring mechanical ventilation. Number fourth is there is no evidence of circulatory overload like JVP will not be raised, no hypertension, no response to diuretic. Fifth is there is no pre-existing acute lung injury prior to the transfusion. If a patient already has the ARDS before transfusion, you can diagnose as a possible TRALI. So the product most frequently implicated for TRALI is FFP, platelets, packed red cells, essential anaplasma containing products. Multiparas female donors are historically recognized higher risk source due to HLA antibodies from pregnancy. The mechanism behind the TRALI. There is a two-hit model which is important pathophysiology for the TRALI. The hit one is the patient, the predisposing condition of the patient. The first hit is provided by the patient underlying condition, the critically ill patient, post-surgical patient, those with sepsis or pneumonia have primed neutrophils that are sequestered in the pulmonary microvasculature. These prime neutrophils are then sensitized, here trigger state ready to mount a massive inflammatory response. Without this first hit, transfusion alone rarely causes TRALI. So this explains why not every patient who receives antibody containing blood develops TRALI. Hit 2 is the transfusion trigger. This is the detonator. The two main mechanisms are immune mechanism first, that is the donor anti-HLA class 1 antibodies or anti-HNA antibodies in the donor plasma recognizes corresponding antigen on recipient neutrophil. Now this will activate the antibody neutrophil interaction which lead to massive neutrophil activation. Then the non-immune mechanism, that is the biological response modifiers Lipid cytokines, reactive oxygen species accumulated during the blood storage, directly activate prime neutrophil without requiring specific antibody. The result, massive neutrophil activation, causes the release of proteases, reactive oxygen species, arachidonic acid metabolites, which lead to pulmonary capillary endothelial damage, then capillary leak, which can cause protein-rich fluid flood alveolar spaces and lead to non-cardiogenic pulmonary edema. That is your ARDS picture. Why multiparous donor matters? Women who do have pre-pregnant develop HLA antibody against the paternal antigen. These antibodies are present in the donor plasma. Male donors and nulliparous female donors much lower rate of HLA antibodies is present. This lead to policy change of preferential using male donor plasma for FFP and platelets in many countries including US and UK, which has substantially reduced the TRALI incident. The TRALI, there is no specific antidote. First of all, you have to immediately stop the transfusion, keep the IV access open to the normal saline. Second is the respiratory support. Start with the high flow oxygen immediately. If the patient is not maintaining SpO2 more than 90%, you can escalate to the NIV CPAP or BiPAP. If the NIV fails, then the patient needs the intubation and mechanical ventilation. Third step is the hemodynamic support. Fluid resuscitation if hypotensive, IV crystalloid bolus. If there is JVP is normal, low fluid giving is safe and necessary for the hypotension. Then vasopressor, noradrenaline if fluid resuscitation is insufficient. TRALI is not a fluid overload, so avoid diuretics. The edema in the capillary leak is not because of the hydrostatic pressure. Diuretic, first of all, they will worsen the hypotension. Second, they can cause renal failure. And third, not remove the alveolar fluid. This is the most common clinical mistake in the TRALI management. So never give TACO, transfusion-associated circulatory overload. The mechanism here is completely different from the TRALI. TACO, as it is saying, a clinical diagnosis based on the fluid overloading lead to the cardiogenic pulmonary edema. What is the mechanism behind it? So the mechanism include the iatrogenic volume overload. Means when a blood component are infused too rapidly or in excessive volume for the patient cardiac reserve, the left ventricle cannot handle the increased payload, which result in the left ventricle and diastolic pressure rises, pulmonary venous pressure rises, and the hydrostatic pressure exceeds the oncotic pressure in the pulmonary capillaries, which can force the fluid into the alveolar spaces. So this is a cardiogenic pulmonary edema, exactly the same as flash pulmonary edema from the acute LV failure. The patients which are at risk are the elderly patient because in those patients reduced cardiac reserve and compliance will be there. So even 1 unit PRBC can overload a frail elderly heart. Second is the pre-existing cardiac diseases, cardiomyopathy, ischemic heart disease, heart failure. Third is a renal failure patient, reduced ability to excrete the volume and the patient is on dialysis are extremely at high risk. Also consider the patient is having the severe anemia. These patients have a compensatory high cardiac output. So we have to be very careful. How we can prevent slow transfusion rate in the high risk patient over 3 to 4 hours per unit rather than 1 to 2 hours. Give diuretic between units in a high risk patient. Limit units of transfusion in these patients and restrictive transfusion strategies need to be followed in these patients. Next, we can manage TACO. First is positioning. Sit the patient bolt upright, that is 90 degrees if tolerated immediately. This is the single most rapid intervention available. Why? What is the mechanism behind it? Sitting up reduces the venous return to the heart, so reduces the preload, which reduces the pulmonary venous pressure and symptom relief within minutes. Also help with breathing mechanisms and upright position improves the diaphragmatic exertion. Step 2 is oxygenation. High flow oxygen via non-rebreathable mask or CPAP if not maintaining the saturation. Step 3 is the fluid removal. In this, you will give the diuretic IV furosemide. This will promote the rapid renal excretion of the excess volume that was transfused within 15 to 30 minutes of IV furosemide. Diuresis begins and pulmonary venous pressure falls. So critical contrast here is in TACO, give the diuretic, it is a life-saving treatment. Whereas in TRALI, do not give the diuretic. This is a comparison slide of TRALI and TACO. So mechanism. In TRALI, there is an antibody immune mediated capillary leak which can cause the non-cardiogenic edema. So low JVP, low BP. Whereas in TACO, there is a volume overload which can cause hydrostatic pressure overwhelms, cardiogenic edema, and there will be high JVP and high BP. Blood pressure is the most clinical useful bedside differentiator. For TRALI, there will be hypotension, capillary vasodilation, and leak reduces the circulatory volume. For TACO, there is hypertension. The heart is receiving too many products which will increase the preload. BP is high from the fluid overload. When a patient develops a pulmonary edema during the transfusion, low BP, think of the TRALI, and high BP, think of the TACO. JVP or CVP. In TRALI, normal or low, no fluid overload, whereas in TACO it will be raised, evidence of the volume excess. BNP and pro-BNP in TRALI, normal, only mildly elevated as heart is not stressed, whereas in TACO it will be mildly elevated. BNP will be more than 250 pg by ml in the TACO patients because cardiac strain biomarker. BNP, it is a cardiac strain biomarker. It is a most useful investigation to order at the bedside. Response to the diuretics. In TRALI, there will be no improvement. Patient will get more worsen. Whereas in TACO, yes, there will be rapid improvement. Diuresis remove the excess volume. Additional differentiating features will include chest X-ray. In TRALI, the heart size will be normal, whereas in TACO, there will be cardiomegaly. Onset in TRALI, it is typically earlier during the transfusion, whereas in TACO, it can be up to 6 hours after the transfusion. Fever can be present in TRALI but cannot be accepted in the TACO. This is the chest X-ray slide. So in TRALI chest X-ray left image, there is a normal heart size. This is a key radiological feature. The cardiac silhouettes, it's not enlarged, and the cardiac thoracic ratio is less than 0.5. You can see diffuse bilateral infiltrates, that is batwing or butterfly pattern, sometimes described as these words. So you can see bilateral fluffy non-homogeneous infiltrates extending from perihilar region outwards. There is no pleural effusion typically. So in clinical words, we can say the infiltrates present, that is alveolar flooding from the capillary leak. This is a protein-rich edema, fluid like ARDS, not the cardiogenic. Whereas in TACO, the right image, you can see there is a cardiomegaly. That is enlarged cardiac silhouettes, cardiac thoracic ratio is more than 0.5 and the failing heart enlarges under volume stress. You can see bilateral infiltrates, which is similar distribution to TRALI in appearance, but the context is different. Pleural effusion, often bilateral, seen as blunting of crostophrenic angles, more commonly in TACO than in TRALI. Upper low pulmonary vein dilation, an early sign of raised left atrial pressure. In clinical words, this infiltrate present as the cardiogenic edema from the hydrostatic back pressure transmitted from the congested left ventricle. So in clinical practice, these two conditions can look identical on chest X-ray. This is why the clinical differentiation BP, JVP, BNP response to diuresis is important. We cannot rely on the chest X-ray alone. So this is the master transfusion reaction protocol. So the origin, that is the root, any suspected reaction, stop the transfusion and assess the A, B, C, D, E. The first response, universal response, is same for all the reactions. Stop the transfusion, assess the patient systemically using the ABCDE approach, that is airway, breathing, circulation, disability, exposure. Then branch 1 is the fever and skin manifestation. So this is a milder branch. This is having fever and urticaria pathway. Left side, fever plus No hemolysis, the diagnosis is FNHTR, management is paracetamol or antipyretic drug. Exclude AHTR and sepsis and restart at a slower rate when it is excluded. Then the middle leaf is the urticaria, pruritus only, that is no systemic involvement. The diagnosis is mild allergic reaction. The management is antihistaminic. Branch 2 is the respiratory distress and shock. This is a serious branch. So in this, respiratory and cardiovascular collapse pathway occur. So the left side, it states that immediate shock or bronchospasm. The diagnosis is anaphylaxis and the management is adrenaline. Then the middle leaf is hypoxia plus hypotension plus normal heart, that is TRALI. Management is oxygen and ventilator support. Avoid diuretic. The right leaf states hypoxia, hypertension and raised GVP. Diagnosis is TACO. Management is sit up and give the diuretics. There is a key differentiating features. If hemolysis is there, check for the AHTR, which is covered in the part 1. Speed of onset, anaphylaxis in second, FNHTR in 30 to 60 minutes. Blood pressure, TRALI is having low BP, TACO is having high BP. This is the bedside TRALI versus TACO differentiator. Diuretic is a treatment for TACO, not for the TRALI. And this brings us to the end of our transfusion reaction part 2 on transfusion vitals. Before we close, here is a rapid fire summary for the key take home messages for all of you. FNHTR, most common reaction, diagnosis of exclusion, always exclude AHTR and sepsis first, treat with the paracetamol. Allergic anaphylaxis, mild urticaria only, histamine, you have to give antihistaminic drugs and can restart the transfusion. Anaphylaxis, systemic collapse, IM adrenaline to be given. IgA deficiency is the key mechanism for the anaphylaxis. Future products, IgA deficiency or wash. TRALI, leading cause for the transfusion-related death, 2-hit model, primed patient or antibody BRM triggers, non-cardiogenic pulmonary edema, hypotension. Treatment is the oxygen plus ventilation. Avoid diuretic and report to the blood bank. For TACO, it is the most underreported complication, volume overload, cardiogenic edema, hypertension, raised GVP. Risk patients are elderly, cardiac disease, renal failure. Treatment is to give the diuretics. So TRALI versus TACO, we have already discussed. Thank you for watching. If this video helped you, please subscribe, like and share with your colleagues. Drop your question in the comment box. And as I read everyone comment, so stay tuned for the next transfusion vital video in the series.